Today we'll discuss about acetabular wall fractures. Fractures of the posterior wall of the acetabulum are most common acetabular fracture type, accounting for approximately one quarter to one third of all acetabular fractures. Only 30% of the posterior wall acetabular fracture involve a single large fragment. That means 70% of the times it is a multi-fragmentary or have areas of impaction. Coming to the treatment of the posterior wall fractures, the non-operative treatment is indicated if the hip joint is congruent and stable. Operative treatment is indicated if the hip joint is incongruent and unstable. There are some recommendations on the fragment size. Some people recommend if it is more than 40% or more than 50, more than 65%, like that. But there is no clarity on fragment size. The best is the congruency and hip stability. The hip instability demonstrated on evaluation under anesthesia. Better to evaluate under anesthesia. And hip incongruency due to the intra-articular fragments and fractures involving more than 50% of the posterior wall are considered indications for operative treatment of the posterior wall fractures. Unstable hip, incongruent joint, and fragment size more than 50% of the posterior wall. Dynamic hip stability. Instability of the hip joint after posterior wall fracture is often difficult to predict, and evaluation under anesthesia is generally needed for treatment decision making. This dynamic test is done under general anesthesia. Employ is entire body weight axially, and you have to perform the test twice. Take an anterior, posterior, and obturator oblique views and check the stability in 20 degrees adduction and 20 degrees internal rotation. Widening of the medial clear space or a loss of joint parallelism is an indication for surgery. Given the low risk of the stress examination and the inherent problems making the computed tomographic measurements, dynamic fluoroscopic stress testing under general anesthesia should be the preferred method for the determination of hip stability after posterior wall fractures of the acetabulum. If the hip is stable in dynamic hip stability test under anesthesia, then surgery is not required. You can mobilize the patient with a support, but you have to avoid adduction more than 20 degrees, internal rotation more than 20 degrees, and flexion more than 90 degrees for 6 weeks. Technique of open reduction and internal fixation. Through Kocher Langenbeck approach, open the hip joint, inspect the interior of the joint, clip the wall fragment into its bed, place intrafragmentary lag screws or KYS, place a reconstruction plate and check under CR and fix it properly. 4 to 5% of the patients will have a cortical impaction of the posterior wall. Preoperative imaging should be scrutinized to identify this clinical entity. As part of the preoperative plan, surgeon can anticipate the cortex available for reduction verification and whether any additional steps or altered surgical approaches are needed to achieve an anatomical reduction. Coming to the fixation methods. Stable anatomical fixation of the acetabular fracture gives the best chance of successful outcome, while penetration of the acetabular articular surface with the screws is associated with poor outcomes. The three fixation methods are posterior wall rim plate, posterior wall buttress plate with a separate lag screws, and a posterior wall plate with a two spring plates. The rim plate was the stiffest construct, followed by spring plate and a buttress plate model. Where possible, a rim plate with a intrafragmentary lag screws should be used for isolated posterior wall fractures, as this is the stiffest and most stable construct. When this method is not possible, spring plate fixation is safe and a superior alternative to posterior buttress plate method. Some patients will present with a fracture dislocation of the hip, fracture of the posterior wall and dislocation of the hip. Some patients will present only fracture of the posterior wall with a minimum subluxation or no subluxation. There was a study published in 2018. There was not a significantly difference of clinical and radiological outcomes between the two groups. The reduction quality and Matta radiological scores were correlated significantly to groups. Posterior dislocation may not negatively affect clinical and radiological outcomes. According to this study, only difference which makes is the quality of the reduction. There was a one study published in Injury 2014. Fractures of the posterior wall of the acetabulum, treatment using internal fixation of the two parallel reconstruction plates. The percentage of the clinical excellent to good and fair to poor results were 93% and 7% respectively. Clinical outcome had no correlation with the age, operation time from injury to the operation, nor had a correlation with the hip dislocation, comminuted fracture condition, and marginal compression of the fracture. The anatomical reduction was significantly correlated with the excellent to good clinical outcome. Necrosis of the femoral head and heterotrophic ossification were prone to decline the outcome of acetabular fracture despite good fracture reduction. The internal fixation of the two parallel reconstruction plates facilitated rigid fixation and avoided fracture fragment injury, was an effective and reliable alternative method to treat fractures of the posterior wall of the acetabulum. Complications can include sciatic nerve injury, incidence is 3 to 18%, heterotrophic ossification 7 to 20%, osteonecrosis of the femoral head 5 to 8%. Despite the relative simplicity of this acetabular fracture, unsatisfactory outcomes after surgical repair of the posterior wall occur in at least 18 to 32% of the cases, results that are worse than for most of the other complex acetabular fracture patterns.